This meeting is being recorded.
Welcome to our webinar titled ASH 2021 Updates, MDS and Secondary AML. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Elizabeth Griffiths. Dr. Griffiths is a clinical assistant professor at the State University of New York at Buffalo and is a faculty member of the Roswell Park Comprehensive Cancer Center. She joined Roswell Park's Leukemia Service in the Department of Medicine in March 2010, following completion of a 5-year medical oncology and hematology fellowship at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Hospital in Baltimore, Maryland. Dr. Griffiths treats patients with blood disorders, specifically acute myeloid and lymphoid leukemias, as well as bone marrow failure syndromes, such as aplastic anemia and myelodysplastic syndromes. It is my pleasure to welcome Dr. Griffiths today.
Thanks for having me. Appreciate it. I was just realizing that my computer was about to die, and so I had to address that problem. Okay, so let me figure out if I can get this thing to share my screen properly. We managed to get to work beforehand. There we go. Can you confirm that you see my screen correctly?
It's showing, just need to put it in presenter mode and go back to the beginning.
Okay, sorry. I thought we had it all set up and somehow when I, okay, let's see here. Nope, that's still not working, I imagine, right?
Just need to be in presenter mode.
Here we go. Perfect. Okay. Does that work now?
Perfect. Thanks, Dr. Griffiths.
All right, everybody. Thank you. Sorry about those technical difficulties. So my brief today was really to speak about the recent ASH meeting and to review some of the highlights of abstracts that were most relevant to patients with myelodysplastic syndrome and therapy-related acute myeloid leukemia. Throughout this talk, if there are things that are of specific interest, please feel free to ask questions, and I'm happy to dive deeper. I have about 40 slides today, and we can address them in detail after the talk. So as an overview, I'm going to review the new risk model that was recently published at the ASH meeting, which hopefully will be ready for prime time in the very short order, which allows us to incorporate molecular mutational events into prognostic scoring systems in addition to clinical prognostic features of the disease. I'll talk briefly about some of the newer therapies that are available for patients with lower risk MDS, those therapies that are being tested in patients with higher risk MDS or TAML, and I'll touch on some precision-based myelodysplasia-related therapies that are in the offing. I'm going to forego the slides on CMML since that was not part of this topic, and I felt that it made the slide deck too long. So many of you will already be familiar with the older mechanisms by which we score and predict longevity for patients with newly diagnosed myelodysplastic syndrome. The most well-recognized of these is the IPSS, or the International Prognostic Scoring System. This was originally developed in the late 90s and used very familiar clinical features, including bone marrow blast percentage, cytogenetics, kind of codified into 3 different groups: those with what we described as better risk cytogenetic abnormalities, those with poor risk cytogenetic abnormalities, and those with other abnormalities, and then the degree of cytopenias. This was the mainstay of our prognostic scores for many years. And then in 2012, largely with increased nuance related to cytogenetic events, because we had a larger cohort of untreated patients that we could use to use cytogenetics as a molecular marker of disease severity. We were able to delineate 5 different cytogenetic risk categories instead of 3. There was also increased recognition that lower blast percentage were associated with less likelihood of disease progression. And there was recognition that the deeper the degree of cytopenias, the more likely people were to do poorly. And so this revised international prognostic scoring system has really been the mainstay of prognostication for us since 2012 when it was first published. And now we are looking to the future with the addition of mutational profiling. Mutational events are a common feature of myelodysplastic syndrome. On average, there will be about 2 mutational events per patient, although there are some people who have many more mutational events. You can see here a spectrum of mutational events in combination with frequently recurrent cytogenetic abnormalities. You can see the frequency of SF3B1, which is identified as a good risk molecular event, and mutations in TET2, SRSF2, ASXL1, among the most common features of MDS disease. Deletion 5q, again, present in a percentage of patients here in this cohort, and other cytogenetic and molecular characteristics. For a long time, we recognized that these molecular events were important, with more mutations very frequently associated with worse outcome for patients, but we weren't really able to incorporate this into our standard prognostication model. At this year's American Society of Hematology meeting, Dr. Papamanuel's group presented data for a newly evaluated molecular risk model, which incorporates both clinical features of disease, including blast percentage, cytopenias, etc., with recognized molecular events. And what they found was that, as we suspected, mutations in TP53, particularly multi-hit mutations in TP53, were associated with adverse outcome, as were mutations in the MLL gene, mixed lineage leukemia gene, and FLT3 mutations. These were present at relatively low percentages in the population, but were associated with adverse risk. There were also some mutational events that were associated with more favorable outcome. This includes mutations in SF3B1 when seen in association with deletion 5q, SF3B1 beta and alpha gene mutations. And this helps us to discriminate patients more carefully into those whose disease is more likely to behave in an indolent fashion from those whose disease who is more likely to be more aggressive. This also extends the application to patients with therapy-related MDS and provides increased discrimination. So hopefully in the very near future, we will have a web-based calculator with strategies to handle missing variables, such that your doctor or you yourself can enter your clinical and molecular variables into a web-based portal. If there are details where you don't have the data, you can say not assessed, and this will allow you to figure out what your score is and predict longevity. This should be relatively straightforward to use, and hopefully will allow people who see patients less frequently with myelodysplasia to help with prognostication. Okay, so once we have prognosticated for patients, then we have to decide what to do. And for lower risk disease, this rubric provides some kind of idea about what to do. This was published, oh, goodness me, sorry. This was published by Dr. DeZern at the ASH educational session that I was lucky enough to share with her. And largely what we do is we divide patients into those who are symptomatic from their cytopenia and or those who have higher risk mutations from those people who are largely asymptomatic and non-transfusion dependent. For people who have non-transfusion dependent disease who are deemed lower risk, often watchful waiting is the right thing and nothing should be done. By contrast, with people who have symptomatic disease, those with cytopenias or those who have low risk disease associated with potentially higher risk mutational events, we divide our treatment based on what is the presenting cytopenia. If patients are anemic, we generally will think strongly about using erythrocyte stimulating agents, or for those with ring sideroblast disease, consider about luspatercept. For patients with deletion 5q syndrome, or even those with no cytogenetic abnormalities, there's an increasing use of lenalidomide in these patients. And these patients should be evaluated usually, I would say, after 8 weeks of trial of therapy. And if they have no response, then we should consider an alternative approach. For people with thrombocytopenia, thrombopoietin agonists are sometimes used. This is particularly important to be done in the context of a clinical trial, as there's been some concern about accelerating disease in people using thrombopoietin agonists. In the NCCN guidelines, we recommend consideration of thrombopoietin agonists in the context of patients who have truly low risk disease, where one is also thinking about immunosuppressive therapy. And then one can think about lenalidomide or hypomethylating agents or a clinical trial. For people with planned cytopenia, one could consider immunosuppression therapy or transfusion support or a clinical trial. And again, reassessment of low risk patients serially is critically important to make sure we're not missing people who have disease progression, and then consideration of allogeneic transplant if any high risk features appear. So at this year's ASH meeting, there was publication on data using lenalidomide with or without L-trombopag. L-trombopag is a TPO mimetic or thrombopoietin mimetic, which has been approved for use with for patients with aplastic anemia and for people with ITP. And in this study, patients were randomized to receive either lenalidomide alone or to receive L-trombopag. And if they did not respond, they could switch to L-trombopag and then restart their lenalidomide. This study ended up enrolling 52 patients. Arm A, 28 patients received lenalidomide. Arm B, 24 patients received L-trombopag. There were 3 deaths, and 1 patient developed fibrosis, which is a concern in people who are getting L-trombopag after 6 years. 1 patient had an irreversible increase in peripheral blasts during an episode of acute cholecystitis. You can see here the overall response rate for both, for the study as a whole was 35%. In the combination arm, responses were 33%, lenalidomide alone 38%, and L-trombopag alone 33%. Fundamentally, what I would say about this is that it suggests that there is activity of both these agents for patients with lower risk disease. And I have certainly used them both with success. Additionally, at this year's ASH meeting, Guillermo Garcia-Minero presented data as a subset analysis from our oral decitabine cetizuridine study for patients with lower risk MDS. These patients all actually had at least intermediate 1 risk disease. You can see here 69 of the patients we enrolled in this study actually ended up having lower risk disease by IPSS. By revised IPSS, most patients actually had intermediate disease. Most of these patients, in order to gain access to the study, were red cell transfusion dependent or platelet transfusion dependent. And you can see here responses were about what we'd expect with survival, which was pretty good here. And you can see here that for those patients who went on to transplant, or those who did not go on to transplant, at least with the follow-up that we have so far, these patients seem to do pretty well, not surprisingly, since they had lower risk disease. There's currently a dedicated study using alternative dosing schedules for oral decitabine cetizuridine in patients with truly intermediate 1 or low risk disease who warrant treatment with a hypomethylating agent, and we're investigating lower dose schedules and lower doses of decitabine cetizuridine. I'll just make one comment about decitabine cetizuridine. The tablet, which is brand name Inqovi, this drug is a fixed dose combination tablet. The drug that's currently available on the market, containing 35 milligrams of decitabine with 100 milligrams of cetizuridine. And this is identical with IV decitabine. And so the issue here is that for patients with low risk disease, this approach may be a little bit too intensive, unless you have significantly lower counts and warrant treatment. So we're looking forward to those data from the new study. So this is a summary of those 2 studies which were presented, which I think are most relevant for lower risk MDS therapeutics. And you can see here summary. Time to response was as we would expect with these agents. It takes several weeks to respond, median time 10 and 12 weeks overall, and duration of responses were pretty long. So for frontline therapy for patients who are HMA appropriate, that is to say higher risk patients, as a physician, we're often a little bit blind to the impact of hypomethylating agents on patients' quality of life and on the burden of treatment. This is what the NCCN guidelines tell doctors what to do. They say divide one's patients into those who are either transplant eligible or non-eligible. And if they're not eligible, consider clinical trials or azacitidine or decitabine, or now decitabine cedazuridine. And we are recommended to treat patients for a minimum of 4 to 6 cycles to assess response and continue these patients as maintenance. In my recent ASH meeting, one of the things I did is I looked through what patients report, and I need not tell this to you, but this can be quite a daunting prospect. I often tell patients when we start that I'm going to start people on prophylactic antibiotics, antifungals, and antivirals, and this means 7 new pills every day. For the first cycle of treatment, if you're getting a parenteral drug, that is to say, if you're getting the drug as an injection or as an infusion, you have to come to the clinic every day. And a recent study by Dr. Zaidan suggests that many people travel in excess of an hour from their home to the clinic. And this can be quite a burden, since once you get to the clinic, you might take 3 to 12 hours of time to sit in the clinic. And many people are not able to drive, and so they need to find somebody to drive them, and one can get painful bruising. And then I recommend that patients come in 2 days a week for a count check. And again, these count checks can take a while, especially if you need a transfusion. This entails extra expenses for parking, gas, and meals. And one repeats this experience every 4 weeks for at least 2 to 4 months until we see a first response. And so this can be a real burden for people. And so what we know about treatment with hypomethylating agents is that, unfortunately, I can't tell you sitting with you in clinic who of the patients that we treat is going to be responding to treatment. We know that early supportive care is really important, so that twice a week count check is critical, and transfusional support is also important. And of course, many of you are aware with the recent shortage in blood products from the Red Cross nationally, both blood and platelet transfusions have been challenging to get. We know that treatment with prophylactic antibiotics, antivirals, and antifungals can help to mitigate the risk of infectious complications, especially early on. And we know that people who get treated with hypomethylating agents should really stay on treatment. They should get treated once every 4 weeks, at least for 4 cycles, and then reassess. Optimal responses can actually take, in some cases, up to 12 cycles. And so keeping people on schedule, on treatment is really critical. But unfortunately, a lot of people don't get this treatment on schedule or for the number of cycles that would be expected to result in a potential for response. Many series show that less than 50% of people who are potentially appropriate to receive a hypomethylating agent do get treatment. And the things that are predictive for not getting treatment offered are things like older age, not having a partner, more comorbid conditions, and poor performance status. And even in those who do start treatment with a hypomethylating agent, up to 30% of people will discontinue treatment before cycle 4, most of those people after only the first cycle. And cycles are often delayed, so they're not given every month, as I told you is critical for response, but instead they're given every 90 days. And unfortunately, this means that those people who get treated in this fashion are likely to accrue all of the toxicity from the hypomethylating agent and really none of the benefit. And so there's a huge opportunity to optimize treatment for people who get started on hypomethylating agents, and things like patient selection to make sure we've got the right patients to get treatment, consideration of transfusion goals for people, and reorienting to provide patient-centered care. Such that we can do local blood count checks so that people don't have to come every time, potentially offering treatment at home, either via direct home infusion approaches, which are being trialed in Italy, or potentially through switching to an oral hypomethylating agent might improve outcomes for people. So for high-risk MDS at this year's ASH meeting, there were a couple of novel combinations. So the first that I'll highlight is a drug called sabatolimab, which is an anti-TIMP3 inhibitor, monoclonal antibody, which was given with hypomethylating agents in people with high or very high-risk disease and those with low blast count AML. This was a phase 1b study presented by Dr. Brunner. The patients were randomized to, it could receive the hypomethylating agent of either decitabine or azacitidine. Patients who had previously been exposed to hypomethylating agents were excluded from treatment, and then they received their sabatolimab on day 8 and day 22. The median duration of response was 17 months on this study, with 54% estimated 12-year progression-free survival. Complete remission was relatively high, with CR plus overall response rate of almost 60%. And this was similar for very high and high risk disease, and seemed to be similar across whether or not patients had bad risk mutations, including TP53, or at least one adverse risk mutation. So far, this combination has been found to be safe and well tolerated. There have been no DLTs, only one treatment-related death. This study is ongoing, and the company is proceeding to a registration trial. So this looks very promising. Again, this is a TIMP3 inhibitor. TIMP3 is thought to be a checkpoint inhibitor. It's expressed both on leukemia or MDS stem cells as well as on T cells. And the hypothesis is that it interrupts the cancer cell producing agents that expand that cancer cell's ability to grow. And it may also enhance anti-T cell recognition by the cancer. So this is an exciting agent that seems to be still quite active. Second study that was presented with greater follow-up was the pevonedistat plus azacitidine versus single agent azacitidine alone as first-line treatment for higher risk MDS, CMML, or AML with 20 to 30% bone marrow blasts. This is the randomized phase 3 Panther trial. As many of you may already be aware, this trial failed to meet its primary endpoint. So far, 324 MDS patients were enrolled. They were randomized 1-to-1 to receive single agent AZA or pevonedistat plus azacitidine. Treatment was repeated every 28 days. You can see here event-free and overall survivals were very similar across the two arms. There seemed to be better response in people who got more than 3 or more than 6 cycles. There was balanced distribution of poor prognostic and frequently mutated genes across both arms. Unfortunately, as I said, this study did not meet its primary endpoint. There seemed to be greater overall survival benefit for those who received more cycles. This is a message we're getting, right? So the more cycles you get, the more likely you are to benefit. I think they're still investigating these data, but unfortunately, this suggests that the pevonedistat is probably not going to move forward. So another combination approach, which has been gaining a lot of enthusiasm and which many of my colleagues actually are using routinely for people with higher risk MDS, is the combination of azacitidine or hypomethylating agent with venetoclax. As you may be aware, venetoclax plus azacitidine was recently FDA approved, or venetoclax plus hypomethylating agents recently FDA approved for people with AML. And Jackie Garcia, who's currently in Boston, has presented some of these data before last year and then an update this year. You can see here that this combination is pretty active in people with myelodysplasia. 30-day mortality was pretty good, only 1%. 9% of patients experience an adverse event leading to death. Patients with key mutational profiles, including those with poor prognostic mutations, were responsive to this combination regimen. The overall response rate was 85%. This data is still ongoing, but looks very promising for patients with higher risk MDS. And then you can see I'm part of a group that's studying a combination of oral ASTX727 or oral decitabine in combination with venetoclax in people with AML. This is a study from the MD Anderson Cancer Center where they were looking at this same combination in people with higher risk myelodysplastic syndrome or CMML. You can see here, so far they have enrolled 9 patients. Nausea and vomiting was not observed substantially, and you can see responses were have not been reported yet, but this looks promising in this cohort as well. So probably an oral regimen available in the future. Another approach for higher risk patients is to use a drug that's analogous to what we use for AML patients. The drug CPX351 is a liposomal combination of daunorubicin and cytarabine at a 5-to-1 molar ratio. We use this for people with secondary AML, and in that context, it's thought to be an active agent, and particularly in people who are likely to go to allogeneic transplant. And this was an upfront study using this approach with CPX-351 in transplant-eligible higher-risk patients with MDS. So patients were eligible if they were fit, and if at the time you were initially saw them, you thought you were going to take them to transplant, people received the Vyxeos drug or the CPX-351 as induction. They received a day 14 bone marrow biopsy to assess response to treatment. If they were chemoablated and they had no progression at marrow recovery, they could either go on to receive an allogeneic transplant or receive consolidation with the same regimen. Instead of 3 doses, they get 2 doses. If there was inadequate response, they could receive a second round of induction. Again, this is initially given days 1, 3, and 5, and then the second induction is days 1 and 3, and the consolidation is same day 1 and 3. Overall responses were pretty high. 75% of people went on to allogeneic transplant, and 15 were pending allogeneic transplant. 20 patients have been enrolled, 6 at dose level 1 and 2 at dose level 14. The 30-day mortality was 0 and 60-day mortality was 1%. Again, 80% overall response rate with a high percentage of patients going on to transplant. This combination looks promising, and I think what we're going to be interested in is what is the rate of relapse for patients with high-risk MDS who receive this as an alternative to hypomethylating agents. So another study also highlighting the activity of this agent, CPX-351, again, liposomal daunorubicin cytarabine, treating patients with MDS like they have AML. Patients had to have either intermediate 2 or high-risk IPSS MDS. They couldn't be previously treated. They had to be younger. They received induction and a second cycle if they didn't achieve at least a PR, and then they could receive up to 4 cycles of consolidation or allogeneic transplant. 31 patients were enrolled, 12 patients received at least 1 consolidation, and 29 of the 31 went on to allogeneic transplant. Again, high rates of transplant success, high rates of getting people to response. I think the big picture here is going to be how well do we get people to remain in remission post-transplant, and that's going to require longer-term follow-up. So in summary, these are the options. I think right now, sabatolimab is looking less likely to be successful. CPX-351 in a couple of studies looks very promising. CR rates are high, overall response rates high, a large percentage of patients going on to allotransplant. Aza-venetoclax also looking very promising with a high overall response rate, relatively tolerable, and responses even in high-risk mutations background. And then the pevonedistat plus azacitidine, unfortunately not looking so promising. Okay, so I mentioned transplant for those patients who are deemed eligible. I think transplant remains a cornerstone of treatment for our patients who are younger and fitter at the time of initial presentation. 2 studies reviewed at the ASH meeting by Dr. DeZern in the education setting, both with relatively larger number of patients. We know that outcomes in terms of transplant are pretty good, especially if we take lower risk patients to transplant. You can see here 3-year overall survival, 57%, 3-year progression-free survival, 54% in the EBMT study. Peripheral blood stem cells were from the match-related donor with best outcomes. The CIBMTR study enrolled 116 patients with low risk disease. Favorable outcomes were associated with younger age, no therapy-related myelodysplasia, no TP53 or RAS mutations, no thrombocytopenia, and lower bone marrow blast percentages. The 3-year overall survival in this cohort was 80%, so substantially higher. These are older publications, but unfortunately, and they're worth noting. I think the thing we worry always about is transplant-related mortality. And so in general, for patients with myelodysplasia, we generally wait until the disease is considered intermediate risk. And that's because if you look at models of outcome, you can see that people tend to survive better if you wait on low risk disease. So median survival 5.3 years for those less than 55, 4.7 years for 60 to 65, and 2.8 years for those less than 65. The risk of non-relapse mortality with bone marrow transplant is worse in low risk patients. And so people have a good relapse-free survival, but there is some loss of life associated with transplant for low risk disease. And so we want to wait until people show a little bit of a higher risk disease feature before we take people to transplant upfront. Emerging data, again, supporting the use of hypomethylating agents before transplant. This is associated with a 2-year gain of expected life. Intervention when patients progress to intermediate risk disease seems to improve survival more than waiting until people develop high or very high risk disease. And you can see here the expected gains in survival. I think it's important also to think about whether or not older patients should be offered allogeneic transplant. We always worry about increasing toxicity and increasing risk for graft versus host disease, adversely impacting health-related quality of life. And so this study tries to address that question by randomizing patients based on the availability of a donor versus no donor. And here you can see a subset analysis, which was again presented at this year's ASH meeting. Dr. Nakamura has already published this data from the clinical trial. The primary endpoint of this study was 3-year overall survival as a landmark analysis, and the secondary endpoint was the quality of life by arm assignment, either donor or no donor. And fundamentally, what this study showed is that older patients with donors seem to have similar quality of life to those patients who do not have donors. And you can see here the curves for the FACT-G total score. This is a tool that we use to measure quality of life. Trajectories were similar across patients, and differences between donor and no donor at 18 months favored the donor arm, suggesting that for people who are fit, who have an appropriate donor, allogeneic transplant for myelodysplastic syndrome, even in older patients, still is a rational choice. Importantly, the baseline quality of life assessment was actually a good predictor of survival outcome for patients, whether they did or did not have a donor. You can see here the curves for the donor arm in red, 3-year estimates, versus the no donor arm in green. Quality of life was better for those who had better scores. Survival and quality of life were better for those who had better quality of life. So for patients with relapsed or refractory disease, there were several abstracts focused on this. I think the most important for me was this abstract focused on the combination of venetoclax plus azacitidine for those who have relapsed or refractory MDS. So in this study, patients who had previously received single agent hypomethylating drugs were eligible to receive the addition of venetoclax to their hypomethylating drugs. And you can see here, patients could receive either single agent venetoclax or they could receive combination therapy. And you can see here the concert diagram for this study. They looked then at the preliminary recommended phase 2 dose, and they recommended 14 days of treatment. What they found is that overall responses were seen across the mutational spectrum and across the IPSSR risk category. Responses were similar for those with higher and lower blast percentage, and the CR plus marrow CR rate was highest in those who had blasts higher than the median, not surprisingly, and lower for those who had blasts less than the median. Survival in this study was reasonably good. You can see here a similar study, venetoclax in combination with azacitidine for treatment naive or relapse refractory MDS or CMML. This is from the MD Anderson group. Again, similar dose escalation, identifying the 14-day dose schedule for venetoclax in patients with MDS as the maximum tolerated dose. Responses were seen again across the mutational spectrum in those who were both, and in those who were HMA failures previously. Of course, survival was less good for those who were previously HMA failures compared with those who were HMA naive. But you can see here duration of response, median overall survival in the salvage arm about 10.5 months. So for me, what this data starts to tell us is that it might be reasonable to consider sequencing patients rather than providing people with AZA venetoclax upfront, maybe giving single agent hypomethylating agent and then looking at adding the venetoclax afterwards might buy additional time. In Dr. Zaidan's other abstract presented at this year's ASH meeting, median survival was more like 33 months when people did that as opposed to upfront hypomethylating agent plus venetoclax. The concern is if you give both drugs upfront, survival in people who fail the combination is relatively poor. So I think unless people are going for allogeneic transplant at this point in my practice, I tend to stick with first line single agent hypomethylating agent and then add the venetoclax on at the time of progression or offer a clinical trial with combination therapy. Here you can see outcomes for therapy-related myeloid neoplasms with venetoclax-based salvage therapy. You can see here This was a retrospective study of people binned. Overall, patients who got hypomethylating agent combinations tended to do better. Poor progression-free survival was associated with the presence of chromosome 7 abnormalities, prior radiation, and prior myeloproliferative neoplasms. So in summary, you can see here response rate and overall survival were reasonably good for these combination regimens. In this latter group, these are specifically therapy-related myeloid neoplasms, which tend to do less well. Adverse events were acceptable, and there are dose expansions planned. So one topic that I think is very exciting for the MDS field is the potential utility of new molecularly targeted drugs, which have not yet been available to us. And there were two abstracts at this meeting, one using enasidenib and the other using ivosidenib. These are drugs that are currently FDA approved for acute myeloid leukemia. Enasidenib targets IDH2 and ivosidenib targets IDH1. IDH1 and 2 mutations are observed in patients with MDS, although not at hugely high rates, but it's been very promising and very tempting for those of us who treat both AML and MDS to consider using these drugs in our MDS patients. And so at this year's ASH meeting, we have some data from phase 2 studies looking at these drugs. These are the two studies that were published in parallel structure. On the left, enasidenib, on the right, ivosidenib. This study with ivosidenib looked at ivosidenib dosed at 500 milligrams. And if the patient did not respond, they could go ivosidenib plus azacitidine. You can see here in cohort A, this is higher risk patients who have previously failed azacitidine, offered ivosidenib 500 milligrams a day for 28 days for 6 cycles. Overall response rate was 54%. In cohort B, these are treatment naive, higher risk patients. Again, they received ivosidenib for 3 cycles, and if they did not respond, they could add azacitidine to the ivosidenib. Overall response rate in this cohort was actually 91%, really impressive. And for cohort C, this is lower risk MDS patients who have previously failed an erythropoietin stimulating agent. Overall response rate about 50%, and over here as the cohort of a whole, 26 patients, overall response rate 69% of patients, 69%. For me, this is a really active drug, suggesting really good response, and very well tolerated. We know the side effect profile of these drugs. Patients with IDH2 mutations, again, could get enasidenib. 26 evaluable patients. You can see the cohort A, again, higher risk HMA failure patients getting enasidenib 100 milligrams for 6 cycles, response rate about 42%. Higher risk first line MDS patients, response rate a little lower at 27%. They could receive after 3 cycles enasidenib plus azacitidine. This cohort is not yet fully enrolled or followed up adequately. And in cohort C, low risk patients who failed erythrocyte stimulating agents could get enasidenib, response rate about 56%. Again, overall response rate about 50%. I don't think you can compare these head to head. Again, smaller number of patients, but certainly suggests that ivosidenib and enasidenib have substantial activity for people with MDS and IDH1 or IDH2 mutations. You can see here enasidenib on the left and ivosidenib on the right. These are the Kaplan-Meier survival curves here. Again, patients who have previously failed hypomethylating agents tended to do worse in blue on the top and in red on the bottom, but suggesting this is not a surprise given what we know about those patients. Still, the response rate and the survival is better than we would historically have expected for that population. So another drug that's gotten a lot of press is eprenetapopt, or APR-246. This is the p53 refolding drug. You may have heard before that this drug failed to meet its primary endpoint in the randomized phase 3 study. The idea here is that it might have still activity. This was the data with 74 MDS patients enrolled. Patients who were randomized, people with p53 mutant disease were randomized to received APR-246 IV infusion days 1 to 4 with azacitidine, either sub-Q or IV, days 4 to 10 or 4 to 5 and 8 to 12 and 28-day cycles. You can see our overall survival for this patient cohort, all of whom had p53 mutant disease, was 11.8 months. landmark analysis at 6 months favored the combination arm. Here, you can see patients with absence of non-TP53 mutations had higher CR rates, 52 versus 30%. So we're still hoping that this drug may have activity. There are certainly studies being done in the post-transplant setting that are of interest, despite the top-line data suggesting no superiority for the randomized study. So here's the summary of this. Again, for targeted mutations of IDH1 or IDH2, novel therapeutics with these FDA-approved compounds seem very promising. I think we're still waiting on the final data for the azacitidine plus the APR-246 drug. So in summary, I think it's important to individually look at patients to assess risk prior to beginning treatment. Risk assessment dictates prognosis, but also dictates what therapy is most appropriate. The IPSSR really is the starting point for risk stratification. I hope in the very near future we will have access to the IPSS mole, which will help us to identify patients at lower and higher risk for disease progression using mutational profiling, which I think for a while we've been using clinically, but we haven't really had the opportunity to really prospectively include that in our prediction models. For low risk patients, serial reassessment of disease is important to make sure that those people who are progressing to intermediate risk disease get offered allogeneic transplant, and transplant should still be considered. I think the way to get people to transplant, whether it should be liposomal cytarabine and daunorubicin approaches, combination treatment with venetoclax plus hypomethylating agent, or other approaches, I think the jury remains still out. I think fundamentally at this point, getting people into a lower disease burden state prior to transplant is likely to be a good choice. With that, I think this is my last slide. I'm happy to take any questions or comments, and thank you for your time and attention.
Thank you, Dr. Griffiths, very much for the presentation. We have a few questions. Our first question is, are you aware of any clinical trials for children of MDS patients for like natural history study of genetics that could have predisposed the patient to MDS specifically?
Yeah, so that's a great question. I'm not a pediatrician, and I think
I'm sorry, this is an adult. This is an adult child. I'm sorry. It's an adult child whose mom passed away from MDS.
Okay. So I think there's an increase in recognition that genetic predispositions do affect people, even adults presenting with MDS. At this year's ASH meeting, there was an abstract, which I, just for the sake of time, I did not include here, suggesting that in people who are at younger age at diagnosis, there's a pretty high percentage of genetic inherited predisposition genes, increasingly, particularly the gene DDX41. It has been identified in patients who are at risk for developing AML and as a predisposing factor. I think that the jury is still out. I collaborate with Dr. Lucy Godley at the University of Chicago and with other groups, including Dr. DiNardo at MD Anderson. We are collecting samples from patients who have provoking family and personal history in order to have those banked. And there's ongoing work to try and understand the degree to which inherited predisposition impacts the frequency with which people get hematologic malignancy. I routinely refer my patients who have a provoking family history or present with 2 personal cancers or 2 first-degree relatives to genetic counseling. There are certainly 14 established predisposition syndromes that are now linked to the development of hematologic malignancies. But I think that list is growing all the time, and probably we just don't know enough at the moment to fully identify those risks. But if you have a family member who died of leukemia or MDS, or who had a diagnosis at a younger age, I think it is worth it to consider getting referred to genetic counseling, particularly if that person or anybody in your family meets the criteria. So the general criteria that we recommend testing are if a person has a personal history of cancer and 2 first-degree relatives with cancer. So that means a mom or a dad, a sister or brother, or children. So personal history of cancer and 2 first-degree relatives, or 2 or more cancers oneself. Those are features that for me are of concern.
Thank you. Our next question is, are you aware of any treatments being studied for people with AXL1 mutation?
Not specifically.
Thank you. And our next question is, what is your experience with luspatercept? Can a patient ever not need any more blood transfusions? And what are the effects of luspatercept? And how high does the hemoglobin go before it is stopped? Does one lower dose at one point?
So I think about luspatercept as a fancier version of erythrocyte stimulating agents. In the clinical trial that resulted in FDA approval for luspatercept, patients were eligible who had either greater than 15% ringed sideroblasts or an SF3B1 mutation. And in that population of patients, the patients who were eligible either had to have an erythropoietin EPO level, endogenous EPO level above 500, and therefore were not eligible to receive ESA's first line, or they had to have failed to respond to an erythrocyte stimulating agent. They could not have previously received hypomethylating agents or other disease-modifying therapy. And in that study, luspatercept was given at dose escalation, and the goal was to render patients non-transfusion dependent. Responses were seen in about 40% of the cohort treated. So that means that not everybody responded. For those patients who responded, the average improvement in hemoglobin was about 2.5 grams, and duration of response was pretty good. So what I generally do is I start people on luspatercept. The drug is given every 3 weeks as an injection under the skin. And we titrate the dose every 3 to 6 weeks, depending on the response. And if I see people titrated to the maximum dose who do not respond after at least a 6-week trial of treatment, then I generally would stop treatment if I don't see a good response. I generally would dose reduce people if the hemoglobin gets above 11 grams because we don't want to push people into the normal hemoglobin range as a result of concerns for increased risk of blood clots.
Thank you. Our next question is, are you seeing more and more of combination therapies being studied for MDS or secondary AML?
Yeah, it's interesting. As a field, when we get together, we often talk about myelodysplastic syndrome as being the shoal against which many ships have floundered. Unfortunately, until relatively recently, all of our randomized studies in MDS have failed to show superiority over single agent hypomethylating drug. That's true of the recent Panther study. Unfortunately, we haven't seen the final data yet for the APR-246 drug either, but certainly that looks like that's not done well. You may recall that a few years ago, Dr. Sekris did a study looking at combinations of azacitidine with lenalidomide and azacitidine with an HDAC inhibitor, and compared that with azacitidine as a single agent in the intergroup. And that study, unfortunately, again, failed to show superiority of any of the combination arms over single agent hypomethylating. We are really hopeful that the venetoclax combination data will prove superior when we look at overall survival as an endpoint. Sabatolimab plus azacitidine certainly looks very promising. Again, we don't have randomized data published on that combination yet. There are new combinations coming down the pike with drugs targeting CD47. CD47 is billed as a macrophage checkpoint inhibitor. And this drug essentially is, the idea is that it blocks the don't eat me signal on cancer-associated blasts, which allows the immune system to kill any residual, to eat and kill those cancer cells and then potentially increase immune recognition for those cancer cells. And so that is an exciting possibility. There are several agents targeting CD47 that are in development that look promising, many of these in combination with venetoclax-based therapeutics as well. So still early days for that program, and no exciting stuff was published at this past year's ASH meeting, although we're hoping at the ASCO and EHA meetings we may see some more preliminary data there. So yes, I certainly think combinations are increasingly hopeful in MDS, but I hesitate to speak until we see the final randomized. Unfortunately, at least up to now, nothing has been superior to single agent azacitidine or decitabine.
Thank you. Our next question is, with MDS deletion 5q, when Revlimid fails, what other drugs could be used other than blood transfusions?
So deletion 5q syndrome patients who have previously received lenalidomide can be offered any number of different options. I think it depends a little bit on what the mutational profile, cytogenetics, bone marrow biopsy blasts are. And my recommendation, if a patient has previously been responsive to lenalidomide and loses their response, what I generally do is I repeat the bone marrow, I repeat the molecular profile, and I reassess whether or not a patient has either lost their deletion 5q, or if there has been some evidence of disease progression or acquisition of a mutational event such as TP53, which would predict a more aggressive clinical course.
Thank you. And speaking of TP53, are there any clinical trials that are happening for patients with the TP53 mutation that you're excited about?
So the drug I mentioned, the drugs that I mentioned before that are targeting CD47, they seem to be active in people with P53 mutations. And so the studies that are ongoing are actually offering preferential enrollment to patients with TP53 mutations, particularly in AML or AML with MDS-associated changes associated with TP53. One very important recent publication, which was presented in Blood recently, is kind of trying to make the argument that patients with TP53-driven myeloid malignancy, whether they are described as having MDS or whether they are described as having AML, have a similar clinical course and outcome. And so there's a movement in the field to start thinking of patients with TP53 mutant disease as a single clinical entity, and thinking about those patients for specific therapeutics that may be targeting that P53. Recently at the BMT tandem meeting, there was some nice data presented in abstract form about outcome for TP53 mutant myeloid malignancy who undergo allogeneic transplant. And there has been some degree of nihilism within the field, saying that people with P53 mutations maybe shouldn't be offered allogeneic transplant because outcome is so poor. The data that was recently presented suggests that even though it is true that patients with TP53 mutations who undergo allotransplant don't survive perfectly, there is a tail, and allogeneic transplant can still offer potentially long-term survival for some, maybe 20% of patients with TP53 mutant disease. And so in my own practice, if I have a patient who is otherwise fit, who has a TP53 mutation, I generally would offer them if available, a clinical trial to try and achieve as deep as possible response to treatment before I go to transplant. And in the meantime, I would set them up for transplant and try to get them to transplant at the time when their disease burden is as low as possible. And I think that offers, in my opinion, the best likelihood of positive outcome for patients. There are some studies looking at offering patients with MDS or AML at high risk for relapse post-transplant maintenance strategies. There's a study currently ongoing which is offering azacitidine and venetoclax maintenance approaches. There's a study looking at oral unmodified azacitidine as post-transplant maintenance. We're waiting for that study to read out. And there are some studies looking at vaccine approaches for people in the post-transplant setting. I think my recommendation is always to think about trying to identify a clinical trial in the post-transplant maintenance setting for people with high risk for disease recurrence, with the caveat that I would still send my patients to transplant if they were fit and had a good donor.
Thank you so much, Dr. Griffiths, for your time and your expertise today and sharing all of this wonderful research that's happening with MDS. And for everyone listening, we will be putting together a patient summary of all of what Dr. Griffiths presented today, and you'll receive a copy of that to your email over the next few weeks. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thank you, Dr. Griffiths. Have a great day.
Thank you, Lee, and thank everybody for the excellent questions.